We described the PK/PD properties of antimycobacterial agents differentiated between latent and active pulmonary tuberculosis. We initiated medication regimen for latent tuberculosis and recommended guideline concordant first-line therapy for active pulmonary TB. We also evaluated and managed drug-drug interactions. Now, given a prescription for antimycobacterial agents, provide patient counseling for adverse effects. In general, rifamycins are well tolerated. They may cause some GI effects like nausea, vomiting, diarrhea, and abdominal pain, and they may lead to headache, fever, and pruritus and rash. Rifampin is the most potent drug against tuberculosis, so majority of patients will be on rifampin. It's important to note that rifampin must be taken on empty stomach, and although in general it's well tolerated, the adverse effects are more likely to be experienced by HIV patients. Some patients may experience flu-like syndromes like fever, chills, malaise, malaises, and headache. And this happens several hours after dosing and usually resolves within several hours, so it's not long lasting. While rifampin can lead to some increases in LFTs, it's typically self-limiting and it's not really cause for concern. Now, serious liver injury is usually confined to patients with underlying liver disease due to alcohol, hepatitis, and other hepatotoxins like isoniazid. Very rarely, patients can develop AKI, which is typically due to acute interstitial nephritis with tubular necrosis, and it's not very common. Some patients may experience hemolysis and thrombocytopenia. This is why it's important to monitor platelets at baseline. And when someone develops petechial rash is when we really suspect thrombocytopenia, and we do follow up platelet monitoring to make sure the patient is not developing a severe thrombocytopenia. Some patients may have type 1 hypersensitivity reaction like angioedema, bronchospasm, urticaria, and shock, which is extremely rare. And what is common with rifamycins is this discoloration of body fluids. So typically an orange-red color seen in urine, sweat, and tears, which can often cause soft contact lenses permanently stained. So that's an important education to provide to patients. Now with rifabutin, it does not need to be taken with food, so it's either with or without food. One of the common causes of rifabutin is uveitis, which is basically ocular pain and blurred vision. It can also lead to polyarthralgias as well as leukopenia and the same orange-red discoloration of body fluids as rifampin. Rifampin also needs to be taken with food, so that's one exception. So food actually increases absorption. It is dosed once weekly, so because it's dosed once weekly, compared to rifampin and rifabutin, it's better tolerated. So patients typically don't experience many of the adverse effects as other rifamycins. It can still lead to orange-red discoloration of body fluids. Now let's take a look at isoniazid, which needs to be taken on empty stomach. The same is true with pyrazinamide, needs to be taken on empty stomach. Ethambutol may be taken with or without food. However, considering that ethambutol is part of RIPE, so rifampin, isoniazid, and pyrazinamide need to be taken on empty stomach, and most patients will be taking this under directly observed therapy or DOT, most patients will end up taking ethambutol on an empty stomach anyway, but it's not necessarily required. Isoniazid is associated with hepatotoxicity as the major adverse effect, and that does include hepatitis, which is a black box warning. So patients who do develop hepatitis on isoniazid they need to discontinue it and be evaluated by an expert. Hepatotoxicity for most patients include increases in liver enzymes such as AST and ALT, and they resolve even with continued therapy, so it's not a major problem for many patients. Isoniazid can also result in neurotoxicity. Neurotoxicity includes CNS toxicity and peripheral neuropathy. About 17% of patients receiving at least 6 mg per kilo per day of isoniazid can be expected to develop peripheral neuropathy, and that is mostly because isoniazid does increase pyridoxine excretion, and in fact, one way to reduce the risk of peripheral neuropathy is to supplement patients with pyridoxine or vitamin B6 about 25 to 50 milligram daily to reduce the risk. And patients who are at increased risk of developing peripheral neuropathy include those with poor nutrition or underlying alcoholism, those with diabetes or uremia, HIV infection, or other risk factors. Now, CNS toxicity can also develop, and that includes memory loss, psychosis, or seizures. However, those are relatively rare. Pyrazinamide can cause nausea and vomiting, and it can also cause hepatotoxicity, but less severe than isoniazid. So hepatotoxicity due to isoniazid is significantly more severe than due to pyrazinamide. Polyarthralgia can develop, which is joint pain, and rarely they can be renal failure. Pyrazinamide can also increase uric acid, so hyperuricemia is associated with pyrazinamide, and in fact, this drug is contraindicated in patients with acute gout. And ethambutol is also associated with peripheral neuropathy, but the major toxicity of ethambutol is visual toxicity. That includes optic neuritis, also impaired visual acuity and red-green color vision. And it's not clear if this is reversible. Obviously, if we catch this, the sooner we can catch this, the better the outcomes can be. So that's something that's important for monitoring for patients. Patients should report symptoms of blurry vision promptly and discontinue the drug until confirmatory visual testing can be done. Ethambutol is also associated with increased risk of hyperuricemia. Now, some of these drugs can be very severe, leading to permanent discontinuation of the drug. If a drug is discontinued permanently, it's important to replace it with a drug, typically from a different drug class, as part of the regimen. So management of serious adverse effects often requires expert consultation. Let's take a look at some of the adverse effects. So for GI upset, if the patient is doing self-administered therapy, they may take the medication at bedtime. Obviously, if they're doing DOT, they will have to go to the physician's office, so that would not be an option. And obviously, majority of RIPE regimens must be taken on an empty stomach. So because they are on an empty stomach, taking with food in order to reduce GI upset is not really an option. So what has been tried is that patients may actually take these drugs with an antacid, which may reduce the GI upset. And some experts actually report success with PPIs as well. But given the PPI epidemic, we don't really want to start patients on more PPIs than needed. And occasionally a light snack, with low-fat food such as 1 or 2 crackers, that can also help with GI upset without affecting the drug's absorption that much. With rash, it's important to, obviously all TB drugs can cause rash. It's important to catch the more serious rash. So when the patient is on rifamycin and petechial rash occurs, it may be suggestive of thrombocytopenia. And if the patient has low platelet, it is important to permanently stop rifamycin and monitor platelets until improvement. For erythematous rash, also drugs must be stopped. And because all TB drugs can cause rash, when you basically discontinue all drugs, and when the rash has substantially improved, medications can be restarted individually at intervals of 2 to 3 days. So, you restart one drug at a time because you don't know which one of them caused the rash. So if the first drug was restarted and the rash didn't come back, 2 or 3 days later, you can add the second agent, and then 2 or 3 days after the third agent until the rash comes back. Then the last drug that you added caused the rash and you can discontinue it. Typically, when you stop everything and restart, you start with rifampin first, because rifampin is the most potent drug. So you want to start the rifampin first, and then followed by isoniazid, and then ethambutol or pyrazinamide. Some of these rash reactions can be extremely severe. So, for example, Stevens-Johnson syndrome or toxic epidermic necrosis, and sometimes systemic corticosteroid may be used to treat severe systemic reactions from these drugs. For drug fever, which is basically a diagnosis of exclusion. So if someone has a fever, you obviously look for common causes of fever, like an infection, cancer, VTE, etc. So if you cannot identify a reason, then you can, call this a drug fever. And so if the fever is due to the drug, you basically stop the drugs. And if the drug is stopped, typically the fever should resolve within 24 hours. And then you can restart once the patient is afebrile. And you restart drugs again individually. Every 2 to 3 days, you add one more. For hepatotoxicity, in the absence of symptoms, therapy should not be altered. So if there's a slight increase in AST and ALT, you can continue. And if the patient is symptomatic and ALT is more than 3 times the upper limit of normal, or asymptomatic but ALT more than 5 times upper limit of normal, it's recommended to stop drugs immediately. And then once the ALT goes down to less than 2 times the upper limit of normal, you can restart drugs. With hepatotoxicity, ethambutol is unlikely to cause hepatotoxicity, so you don't really have to stop it. But isoniazid, pyrazinamide, and rifampin will be the likely causes. Rifampin is the less likely. So once you stop the 3 of them, you restart by rifampin first. And then if no increase in ALT 1 week later, you can restart isoniazid. And then pyrazinamide can be started 1 week after isoniazid if ALT does not increase. If symptoms recur or ALT increases, then the last drug added should be stopped. And then lastly, for optic neuritis, the onset of optic neuritis is usually more than 1 month after treatment initiation. And this is typically due to ethambutol. So, it's important to hopefully by a month into intensive therapy, if the susceptibility results are back, it's best to stop ethambutol as soon as possible before this optic neuritis occurs. But, as we know, intensive therapy can go up to 2 months. And then once someone develops optic neuritis, ethambutol should be discontinued immediately. And if still no vision improvement, it's also recommended to stop isoniazid as well, because there have been rare reports of optic neuritis with isoniazid. This concludes this presentation.